Another excellent talk. Thank you so much, Ken. I would like to invite our final speaker to the podium, Dr. Stefanie Blain-Morales, who comes to us locally from the University of McGill, where she is an assistant professor in the School of Physical and Occupational Therapy. Dr. Blain-Morales is a biomedical engineer by training. She works to develop technologies for the assessment of and the interaction with non-communicative individuals, and she receives funding for that work by all three branches of the Canadian Tri-Council. She will speak to us today about how network motives characterize the loss and the return of consciousness in healthy individuals, and then let's extrapolate from that to discuss how the use of an analysis of these motives can help us to gain some insights into the level of awareness in disorders of consciousness. Dr. Blain-Morales, thank you.
Thank you very much, Ines. And I just want to start off by saying how privileged I am to be able to speak at this panel, and how welcoming I find the environment as an engineer coming into a room full of anesthesiologists. Thank you very much. So my talk today, I will be talking about three things. I'm going to start off by orienting us to the challenges that we face in assessing patients with disorders of consciousness. I'll then pivot to talking about insights that we can get from EEG characteristics of anesthetic-induced unconsciousness, and I'll conclude by applying what we know from these EEG characteristics to looking what we can, how we can assess patients with disorders of consciousness with anesthesia. So we've had a number of references to how we define consciousness in the three previous speakers. This pulls it together from a diagram from Stephen Laurie's group that looks at consciousness along two orthogonal axes. Your x-axis is level of wakefulness, your eyes being open, and to put it simply, and then the y-axis being level of awareness, how aware you are of yourself and of your external environment. And for the most part, we exist along this diagonal line, but there are a series of altered states of consciousness that fall off the diagonal, and the two that I really want to focus on in my talk are minimally conscious state and vegetative state. These are two states with high levels of wakefulness, but minimal to no levels of awareness. Minimally conscious state is defined as an individual who inconsistently responds to commands, and we understand vegetative state as individuals who are unconscious, though they are wakeful. We assess disorders of consciousness clinically. One of the tools that has emerged as the gold standard of assessment is the Coma Recovery Scale Revised. Using this tool, we've been able to show that there's a misdiagnosis rate in individuals with disorders of consciousness of over 40%, meaning that about over 40% of individuals who we think are in unresponsive wakefulness syndrome, which is now what we call vegetative state, actually have some level of awareness of the environment. This was further proven in 2006 when Adrian Owen's group showed that with a patient with a diagnosis of unresponsive wakefulness syndrome, they were able to follow commands in the fMRI by asking them to play tennis or navigate a room in their house. And then further follow-up by Cruz and his colleagues was able to show that we can detect consciousness by asking someone to follow commands of left foot movement or right foot movement with EEG recorded at the bedside of an individual diagnosed as in unresponsive wakefulness syndrome. So clearly there is a group of individuals who possess some level of awareness of their environment, which we are not being able to detect. And this likely underestimates these numbers of individuals because right now we are detecting consciousness by asking individuals to follow commands. But there are a number of different factors that would contribute to someone being aware but not able to command follow. Pain, fatigue, for example. So this likely underestimates the number of individuals. So I'm working with a data set of 21 patients with disorders of consciousness. Eight of them come from Adrian Owen's group at Western University, and 13 come from our data collection here through McGill University. For all of the patients, we record 128 channel EEG. during either a resting state or a passive listening task that is meant to evoke event-related potentials, and we analyze the EEG with the analysis techniques I have on the screen. And I want to show, the figure I have up here is just of one small analysis technique. It's the topographic map of where alpha power is in the brain. And canonically, we see that when you have a conscious individual, alpha power tends to be concentrated in the posterior areas of the brain, and under some forms of unconsciousness, you have an anteriorization of alpha. And I want to show you data from 8 of my patients of disorders of consciousness, just to show you, first, that there's no 2 patients that look the same, and second, that none of them look like your healthy controls. And so there is a difficulty that arises when you're working with this population of how do you assess whether they're conscious or not. There's a lot of difficulty in comparing them to healthy controls. And this came to a head in the literature in 2013, where there was a number of studies published in The Lancet that showed that depending on the tests that you use to compare patients with this who are unconscious, supposedly unconscious, to healthy controls, you could get different results through the comparison. So George Mashour and Michael Avedon published a commentary on this in The Lancet that suggested that potentially anesthesia would be a useful tool for for comparing not between healthy and patient groups, but within an individual themselves. So this is the study that we actually conducted. We recorded baseline EEG from an individual while they were at rest, while they were also listening to an auditory stimulation paradigm. Then we gave them a target-controlled infusion dose of propofol anesthesia and recorded their changes in EEG, and then we looked again at recovery. So that's to set this up. Before I get to the results of the study, in order for you to understand them, you have to understand the markers of EEG that we're looking at. So I'm going to pivot to what are the EEG characteristics of anesthetic-induced unconsciousness that we're looking at. This is work that comes from Patrick Purdon and Emery Brown's group that show, we've seen this in the previous talks, that there is an increase in alpha, so 8 to 14 hertz in the spectrogram under propofol induced unconsciousness, and there's an anteriorization of alpha. We've also shown, we've shown that under ketamine-induced unconsciousness and under sevoflurane-induced unconsciousness, we actually don't see these spectral markers of unconsciousness. So in ketamine, we actually see a decrease in the alpha power, and in sevoflurane, we don't see an increase in the alpha power, and we don't see the anteriorization of alpha. So in this study, I did not focus on the spectral properties of the EEG. Instead, I focused on the network properties of the EEG. So I need to take you through a 2-minute tutorial on how we construct a brain network from EEG signals. So on the screen, I have 2 signals, the black signal and the blue signal. And I can get these signals from every single one of my EEG electrodes, and I measure a level of functional connectivity between these 2 electrodes. You can measure functional connectivity in a number of different ways. You can look at amplitude envelope correlation, for example. You can look at phase-based measures of connectivity, and in the work that I'm presenting here today, we're looking simply at phase-based measures of connectivity. So you have here at the bottom left, you're looking at a matrix of 8 electrodes by 8 electrodes, and we calculated the functional connectivity based on phase lag index between all pairs of electrodes, and you can map that onto a network of the brain to show how connected the different areas, the different electrodes on the brain are. You can also map a direction onto this brain network, so we can look at measures of directed functional connectivity. Again, we have the black and the blue signals that are recorded here, and we're looking in direction, we're looking at whether something is phase leading or phase lagging between these 2 signals. So once again, we have, for example, 8 channels on your EEG. We look at the directed which signal is leading, which signal is lagging, and we can get a measure of direction on this brain network that we've constructed through EEG. We have seen this slide as well. The reason that direction is important is because Anchol Lee and George Mashur have shown, among other people, have shown that the direction of information flow between frontal and parietal cortices is a marker of an anesthetic-induced unconsciousness across various anesthetics. And I want to show you this particular figure because you're going to need it in order to interpret the data on the later slides. This is a map of directed functional connectivity, so directed phase lag index, across 128 channels of EEG. We see that in the conscious phase here, red means phase lead, blue means phase lag, so we're seeing a lot of phase lead over here, phase lag over here. And in the unconscious phase, I want to highlight where the frontal parietal connections are. We see either a neutralization or a reversal in the direction of information flow in these networks. Once we build a network, a brain network, we can quantify the characteristics of this network through a branch of physics known as graph theory. So there's a number of ways you can quantify this network. I'm not going to go into detail on them. I just want to point out that several properties of these networks have been shown to vary with anesthetic-induced unconsciousness. This is work that we published in Frontiers of Human Neuroscience through looking at data recorded through the recognition study that shows that clustering coefficient and global efficiency, which are markers of network properties, are significantly different under unconsciousness versus conscious states. But what I really want to focus on here is a property of the network called the network motif. You see that over here. A network motif looks at how the different parts of the brain or how different elements of the network are connected together. So we can build motifs out of 3, 4, 5 different nodes. If we look just at 3 node motifs, there are 13 different ways that you can connect these nodes together. So it's important to notice here that there are arrows. So in motif number 1, we have 2 nodes feeding into a single node. The arrows are important. Here in motif number 2, we have this node feeding into the top node, this node feeding into the bottom node. So 13 different ways that we can connect 3 different nodes together. And if we look at a unidirectional measure of connectivity like DPLI, there are actually only 5 of these that can exist. So we looked at network motifs from high-density EEG collected from a subset of patients from a broader study funded by the McDonald Foundation, run by Michael Avedon, Max Keltz, and George Mashur. And in this study, we anesthetized 9 individuals at the University of Michigan with under 1.3 Mac isoflurane. And we looked at what their networks look like, specifically what the motifs of their network look like at baseline, at induction, right upon 3 hours of isoflurane, 30 minutes pre-recovery of consciousness, 10 minutes pre-recovery of consciousness, 5 minutes pre-recovery of consciousness, and then 30 minutes and then 3 hours after recovery of consciousness. What you're looking at over here is a graph of the frequency of each of these different motifs, and we found that there was no significant difference in how often these motifs appeared in the network across the different states of consciousness. However, when we looked at where these motifs appeared, the topology of the motifs, we saw significant differences across the different states of consciousness. So we're looking here at 3 different motifs, motif 1, motif 2, and motif 7, and we're looking here at a single individual. I'll show you the average in a minute, but I wanted you to see what an individual subject data looks like. So you'll see that in baseline, motif number 1 is mostly constituted by electrodes in the frontal area of the brain. Motif number 7 is mostly constituted by areas in the posterior area of the brain. And upon unconsciousness, this reverses. Motif number 1 is mostly constituted by electrodes in the back of the brain. Motif number 7 is mostly constituted by electrodes in the front of the brain. And if we do this analysis across all 9 of our individuals and get an average graph and run a repeated measures ANOVA on the data, we can find that motif number 1 is significantly different across all states of unconsciousness, both deep unconsciousness and 5 minutes pre-recovery of consciousness. And motif 7 is significantly different in the deep unconscious states, but returns 10 minutes pre-ROC. So just to summarize what I talked about in this section, what I would posit as non-discriminatory features of the state of consciousness, spectral properties, topographic power, and motif frequency don't seem to distinguish between the state of unconsciousness and consciousness. And I would put forward that some of the discriminatory features, we're going to get some discussion about this one, I think, frontal parietal feedback connectivity, properties of the graph theory network that you can put forward, and the motif topography. So how does this allow us to assess patients with disorders of consciousness? We took our subsample of 13 patients with disorders of consciousness, and we anesthetized 8 of them within this within-subject anesthesia protocol. And I want to bring forward 2 of these cases. I selected them not because they were the ideal cases, but because they provided a really nice contrast to each other. So this first case is an individual who is diagnosed with unresponsive wakefulness syndrome. His CLOMA recovery scale revised measure is, he's at a 7. And he's a chronic patient, so we recorded him 8 years after an anoxic injury. When we look at his baseline feed-forward feedback connectivity, we actually see this feedback connectivity from the frontal to the parietal areas. And when we look just at the baseline, we think maybe this patient is actually covertly conscious. Then we anesthetize him, and we see that under anesthesia, unlike what we would expect, the feedback connectivity remains, even though it diminishes a little bit. So that doesn't quite tell us anything. If we look at the graph theoretical properties, this follows the pattern of what we would expect to see under healthy controls. So the asterisk, the red asterisk, is where the patient properties are, and this box plot shows you where the normal population falls. However, when we look at the network motifs, so this is inconclusive in and of itself, but when we look at the network motifs, motif 1 looks nothing like what we would expect in a healthy control, either in baseline or anesthesia, and motif 7 is not even significant. So this is clearly, we don't know the gold standard, we don't know whether they're conscious or not, but the fact that they had been in this state for 7 years suggests that these underlying non-significant motifs are indicative of a lack of consciousness. To contrast this, I want you to take a look at a case of another individual who was also diagnosed with unresponsive wakefulness syndrome. This individual has a coma recovery scale revised score of 4. We recorded his EEG 56 days post-injury, so this is an acute patient. And when we look at his baseline, we see some level of frontal parietal connectivity like we did in the first patient. It again gets diminished, but not necessarily neutralized under anesthesia, and it comes back under recovery. His graph network properties are quite different than what we'd expect from the normal population. However, when we look at the motifs, these are equivalent to what we would see in a healthy individual. Motif 1 is anterior in baseline, posterior under anesthesia, and forward in recovery, and motif 7 exhibits the opposite trend. This individual, we followed up with him 1 month after we did these EEG recordings, and he had recovered his ability to respond to commands. He was able to use tools appropriately. He was able to have conversations with his wife. And so it's interesting to look at the properties of the motifs that underlie a network of an individual who recovered consciousness. So just to conclude, I want you to take away from this presentation that it is difficult to compare the brain networks of individuals with disorders of consciousness to healthy controls because of the heterogeneity. And I want to I hope that you are able to take away that EEG network characteristics, specifically the motif topology, may be an interesting candidate to differentiate between states of consciousness, and that anesthesia is potentially a useful tool to allow us to create this within subject paradigm to allow us to assess patients in disorders of consciousness. this work was, I owe an enormous debt to my students, my postdoc, Catherine Duclos, who's really, who's in the audience here, who has really driven the work on disorders of consciousness, and my two graduate students, Danielle and Yassine, who have owned this motif analysis. The anesthesia protocol that we run with our patients is entirely at the mercy of our clinical collaborators, so I owe them a huge debt. Gilles Plourde is in the audience, Christian Gay is in the audience as well. I'd like to extend my thanks to Adrian Owen's lab for being so willing to share his disorders of consciousness data with us. And a lot of the work that we do characterizing these network motifs and just network properties of unconsciousness and consciousness comes from the recognition study team. And so I'm very grateful to George and Michael and Max for giving me access to this data as well. Thank you very much.
Thank you very much. Thank you again to all of the speakers for some wonderful presentations, very stimulating presentations. I would also like to thank them for staying on time, which has left us with significant amount of time now for questions from the audience and hopefully answers from the panel and some discussion. I'm thankful that the speakers are all back on the panel. I would invite members of the audience to please come up to the microphones. Please briefly state who you are, where you're from, and pose your question, and then hopefully we'll have a fantastic discussion.
I don't know if it is on. John Capacchione from the University of Minnesota. My first question is, can we really equate return of loss of writing reflex with emergence from anesthesia? We all move in our sleep, but we're not necessarily conscious that we're moving in our sleep. And then the other question is, with these mechanisms of anesthesia and emergence, is any of this relevant in the disease states of the brain?
I can start. I think many of us would say that the loss of writing reflex and the return of writing reflex in animal studies is an imperfect surrogate. We're unable to assess the content of consciousness. We don't know what's going on in the mind of the rat. And even some of the data that I've shown, and I think Ken and others would say the same thing, we can't really make any inferences about content. We can make claims about observable levels of consciousness and wakefulness because there are patterns that are relevant independently of what we can say about the content of consciousness. So I do think, and I think we all believe, it's an imperfect surrogate, but there is some consistency in terms of loss of writing and return of writing across the translational spectrum. Can you?
Yeah, I agree with what Dr. Mashor just said. I would just say that it's been shown that the writing reflex is a brainstem reflex, so it isn't a perfect endpoint. It's a difficult question to ask. We like to use the EEG, which is also an imperfect indicator, but at least when we put these things together, we can start to get an idea of whether these are just spontaneous movements versus actual return of consciousness. So I think that the data supports that, but we really can't prove it.
Can I make one comment, which is to leap to the defense of the right of reflex? So my understanding is that when these experiments are done, the animals kind of stimulated intermittently to see if they return their writing reflex. And what we do in volunteer studies of anesthesia is we set the dose of propofol running, we measure the effect of propofol, and we equate that to a state which we think we understand. And it may be appropriate to go back to that methodology that Dr. Radek proposed in his paper, where we're stimulating the patients and finding out what they're actually experiencing in the volunteer literature as well. So maybe we can learn something from the way that writing reflex experiments are done in animals and apply that in the human anesthesia volunteer world anyway.
Catherine Duclos, I'm Dr. Stefanie Blain-Morales' postdoc. Firstly, I wanted to say thank you for 4 very insightful talks. I was wondering, a lot of your research aims to speed up emergence from anesthesia, and I wanted to know if there were any observations in your research, or is there anything in the literature that suggests it would be actually undesirable to speed up this emergence process?
So this is something that we've been interested in. I mean, with our human study, we thought that we might be able to get some sense of that. There have been suggestions that trying to accelerate emergence by giving stimulant medications such as methylphenidate may actually induce delirium or worsen this process, and that there may be a natural process that is preferable than sort of forcing patients out of it. We essentially had a negative result, and we also didn't see any delirium. It could just be based on dose. It is a hard question to answer. Right now, the limited data that we have doesn't seem to suggest that it worsens the wake-up process, but I think this is something that we still need to explore. I don't know if anybody wants to add.
So there are many pharmacological ways of getting rid of consciousness, I see, right? And yet, what are we studying? So would it be useful to use genetic mice? For example, we have the famous GERD mouse, as we call it, which is a knockout on the beta-3 subunit of the GABA receptor. And when I did a collaboration with a group in Madison with a new drug I had, which was a GABAergic, but I thought was insensitive to didn't bind the atomic site, takes an anesthesiologist. What GERD didn't notice was that although they wake up and get up much earlier because there's lower affinity for the atomic on the beta-3, their ability to get rid of ataxia is exactly the same as wild type. The reason probably being that the beta-2 has not been knocked out, and Merck did knock it out, and one of their key results was to do with rotor rod tests and things like this. So it looks like you could actually, if you use genetic manipulation, manipulate which pathways you are, quote, anesthetizing, whatever that means.
Yes, I think that's an excellent suggestion. And I think also, a lot of the work that is now emerging in terms of manipulating specific circuits is involving optogenetics and chemogenetics, and some combination thereof, I think would be important.
I think I didn't show any of this data, but we've been doing some cognitive testing in animals under anesthesia and trying to stimulate these pathways to see what kind of states we've created. And what we found is that the animals look awake, but they're often cognitively still impaired, which isn't too surprising because there's still a lot of isoflurane in the brain, and we've probably only activated a specific circuit to cause them to be awake, but maybe their hippocampus isn't back, maybe their memory is still lost. And so I think that the process of natural emergence, if you will, where we're not stimulating these pathways and they're sort of naturally, spontaneously coming back online, is probably quite different from the work that we've been doing. But I think that using these sort of individual circuit stimulations kind of gives us, it starts to sort of put the pieces together to see what is needed and what isn't needed. And I think that it's a very complex question because even, Max showed that it can be anesthetic dependent, and some circuits may be far more important than others. So.
It's going to be very complicated, we know that.
It always is.
Hi, Andrew Seven, Lancaster, England. I'm just wondering about your Ritalin methylphenidate use. I think historically, methylphenidate was used to prevent abnormal muscle movements, shivering, so-called shivering in emergence. And I think it was effective. I was wondering whether that actually is just an example of cortical control being restored over those motor centers, subcortical motor centers, which were responsible for what we used to call shivering, but is something other than shivering. And whether, in fact, we've known all along that Ritalin does actually work because it's doing something to restore the cortex.
Yes, I'm not too familiar with the mechanisms of shivering, so I don't really feel like I can make an educated statement on that. There is old literature suggesting that methylphenidate may accelerate emergence from older anesthetics like thiopental. It's also a respiratory stimulant, which actually makes it trickier to look at inhaled anesthetics, which go away faster when you're breathing faster. And so these are things that we're sort of confounding the literature, and we're trying to control for these various issues. But I think one of the problems is the anesthetics we have are quick to go away. Now we have these, drugs like sevoflurane and desflurane that are rapidly cleared from the body. So we unfortunately didn't get a clear signal in our study. But we didn't really see much shivering. I mean, these days with bear huggers and things like this, it's not really a common problem. So I didn't really see a difference with that. But I don't know if it certainly could be the case.
Hi, Patrick Purden from Mass General. I had a question for Dr. Blain-Morales. So I think you showed some very compelling evidence about how spatial connectivity and networks change in these different conscious states. And then you made this interesting assertion at some point in the talk about how essentially the dynamics didn't matter. It was really the spatial components that mattered, but the dynamics didn't distinguish between the different states. And I found that kind of controversial, to say the least. I mean, just looking at, say, the data that Rob showed, when you stimulate, for instance, with TMS, you do get this, tremendous, significant evoked alpha oscillation. We know that alpha oscillations, for instance, mediate anterior-posterior connections in attention, and then the anesthesia data, of course, shows pretty decisively that oscillations do change in form during changes in consciousness. And you mentioned something about sevoflurane. If you go to the clinic, you'll see that there are frontal alpha oscillations with sevoflurane, very, very reliably. And then to add to that, the network connectivity properties that you derive from EEG are ultimately derived from dynamics. So how do you then reconcile that? I mean, there's so much richness in the dynamic information that actually gives rise to the spatial component of network connectivity. How is it that the dynamics don't actually inform on your ability to discriminate between these states or conditions?
Thank you for the question. I don't want to. I hope I didn't come across saying that the dynamics don't matter. The dynamics clearly are, like you said, they drive the underlying properties of the brain network. We construct our networks based on the underlying dynamics of the different areas of the brain. What I was trying to say, for example, with the sevoflurane data that I showed, was that just a basic spectrogram, for example, when you look at an individual with the sevoflurane study, we had just put them over the borderline of unconsciousness. This wasn't deep unconsciousness, where you would see anteriorization of alpha. This was just over the borderline of consciousness, and we don't see an increase in alpha power. We don't see an anteriorization of alpha in these cases, even though these individuals are unresponsive to command. So while these dynamics are indicative of different states of consciousness, they can't necessarily mark for us whether someone's unconscious or not. And so what I'm looking for in my work is something that is able to distinguish across whether someone is conscious or not across the different mechanisms. Sorry, I don't know if I answered your question.
I think you did, but I guess maybe what I'm saying is there's a kind of a missed potential, right? A potential opportunity that's missed. I mean, if you know fundamentally that alpha networks, irrespective of anesthesia, are involved in attentional control, apparently they can be evoked when someone is kind of jogged out of a unconscious state into a more conscious state. I mean, why not look there? It doesn't seem reasonable to rule that out, right?
Yes, and we do. Let me just be clear. We do look at this. Like when we do our analysis, we don't just throw away all of that data. We do a topographic analysis. We do phase amplitude coupling analysis. We do look in this area. The data that I presented today was sort of a narrow lens on the broad range of analysis that we do. I certainly didn't want to imply that we throw away all of that rich data.
Hi, I'm Monica Murphy from Richmond, Virginia, and I'm asking a question. I'm an anesthesiologist, but I have a sketchy work history. I'm the mom of 3 boys, and the youngest of whom was just put on Vyvanse for non-hyperactive ADD. And I laughed because when you described a minimally conscious state, that was on the graph, the orthogonal line, I thought that's what my son was, in terms of not following commands. And he has improved at this. But my question goes to this overlap between disciplines. So because I'm not in the weeds like you all are, doing the painstaking work of identifying small increments of knowledge, I'm interested in this whole area of consciousness and how the multidisciplinary implications of it for things like ADD, or another son would have night terrors and get up, and I could coach him back to sleep, but he would have no memory of it. And John Butterworth was one of my faculty members, and he had a patient squeeze my hand with LMA anesthesia, and they had no memory of this. So there's lots of areas where these sorts of things show up in just everyday life, and I'm wondering how, especially, I'm sorry, the researcher from University of Michigan, I'm not aware of the field enough to know your name off the top of my head, but I really liked the whole Center for Consciousness. How are you pulling from different areas? And I'll stop there.
Sure. So thank you for the question. I think that consciousness really represents a very rich opportunity for interdisciplinarity. We have individuals from anesthesiology, neuroscience, biomedical engineering, psychology, philosophy, and there are a lot of different dimensions to the problem. I think in terms of the different domains to which this can extend, I and about 60 other consciousness scientists across the world talked about opportunities for the maturing science of consciousness and how it can move from some of these traditional domains, looking at level of consciousness, coma versus wakefulness, anesthesia versus consciousness, into psychiatric disorders, and how we can start to characterize with more nuance conscious states in these areas. So I think you're spot on, and I think the argument that we want to try to make to, for example, the National Institutes for Mental Health in the US, is that understanding consciousness is really going to be important for a wide variety of disorders. So thank you.
Hello, Alex Project. I'm from Penn. My question is for the network scientist, maybe for Dr. Blain-Morales, maybe for George Mashur. The question concerns these modules, these motifs that happen in networks. Ultimately, what you're doing is you're constructing statistical relationships between pairs of electrodes, whatever you choose to base that on. How do you deal with issues of spurious correlations when you have so many parts that are maybe weakly correlated? That's sort of part one of the question. And another part is, well, how many nodes can comprise a single module? Obviously, the more electrodes, say, you choose to include in a module, the more different combinations of their connectivity could there be. So maybe you could, I'm sorry if this is a bit of a technical question, so thank you.
I'll take that if you'd like. So the issue of spurious correlations is something that we are extremely vigilant about. So for example, when we construct the basic network using either amplitude envelope correlation or phase-like index, we always construct this against a random network. We preserve topological properties, we preserve the spectral properties, but we shift the time series, so we randomize the connection between these individuals, between the two electrodes, and we look at only the connections that are statistically above the random, the chance. So this is the first level of correction that we make. And then when we conduct the motif analysis, we also do a similar level of check. So we construct our network, and then we randomize this network but preserving certain properties of the node. So we will preserve the node degree, for example. We'll preserve certain properties of the graphs, but we'll randomize the connections, and we will calculate the motifs of hundreds of these random networks. And then we look at the motif distribution that we currently have, the frequency of these motifs, and we compare it against this distribution that we get from hundreds of random networks, and we only consider the motifs that appear above chance. So that's, I think that's part one of your question. George, I don't know if you have anything to add to that.
But I mean, it's an abstraction,
Yes.
it's artificial, it's arbitrary, and it's, I mean, not what you're talking about, but in terms of the use of a network, you know,
Trigger existential
Yeah.
crisis. I was just interested in the.
No, I mean, you're
in how
abstracting
it's done.
something. And I think the other thing that's important, just to your second point, is the question of scale. I mean, this is very different than, you know, thinking about a neuronal spiking network and those types of interactions. It's a large-scale brain model, and certainly a lot of information is lost depending on how extensive you're constructing it. So I think if that, you know, that is part of your second question or implication, I would absolutely agree.
You know, I didn't actually mean to imply anything. I just, you know.
I think you did, Alex. Don't.
No.
This is a very sophisticated audience, Alex. Don't try to fool us.
You know, some people say that maybe these higher order correlations are really a consequence of many weak pairwise correlations, perhaps. You know, there are very nice papers on the subject, on maximum entropy models of these kinds of networks, due to Bill Bialik and to others. And there's a certain appeal to that simplicity, that the higher order structure is really a consequence of pairwise things. And it seems like you guys are arguing that no, that is insufficient, and that there are these higher order correlations that are in themselves markers of perhaps consciousness or a disease of the brain, which would be fascinating if true, but very difficult to establish against the sort of the maximum entropy approach. So that was the source of my question.
Hi, I'm Max Kells from the University of Pennsylvania. I'll ask a far less technical question than Alex. I'm interested in your thoughts as to how close we are to having an ideal measure for a neural correlate of unconsciousness, and whether such a measure would be invariant to detect, say, disorders of consciousness or various anesthetic drugs, and must that ideal correlate be able to detect the slide into the unconscious state, whatever its etiology, and similarly the return back out of it?
Well, also, you know, I should have put up a disclosure slide at the beginning to disclose that I really don't know what's going on. Okay, and you know, I think there's been a lot of work in the area, and I think some of the different groups are coming up with some great techniques, but you know, I think just thinking about it from the clinical perspective or clinical research perspective, I don't know if we're going to have sort of the Platonic discrimination between sets that is absolute and inviolable. So I think, and even, you know, with respect to the alpha oscillations in the frontal cortex, I mean, it's probably going to be something probabilistic that might work in certain settings and might not work in others. And I can tell you, I'm not going to reveal all the data, but even this dissociated state that I've shown, where you have an animal that's walking around on 1 Mac of sevoflurane, and you compare that to those that have not recovered, you can find all sorts of dissociations with oscillations, with connectivity, with complexity measures. And so I think usually these are traveling together, but I think they can be dissociated in different states. And as the years go on, I'm getting more and more humble about what I think can work. Now, I will be interested in hearing what others have to say, but I think there is progress, but I think, you know, we have to be careful and thoughtful as all of these techniques evolve.
So can I comment? So Max, I would ask you what you want when you ask that question and what you mean by unconsciousness. And I think that's one of the problems, is that, you know, what I term as a minimal subjective experience may be considered completely irrelevant by another consciousness scientist who wants to know that your subject is able to do Sudoku, right? And I don't think when a patient is responding on the ISO-4 test that they're reaching for a pen to fill out their Sudoku. I think they're squeezing our hand, but they're very probably limited in their cognitive capacity, and we're trying to do a study, Conscious 2, where we'll briefly probe that, and I know you're involved. So I think that we have to come together and make some much clearer definitions and how we apply it. And I think anesthesia, the literature in anesthesia would benefit from that clarifying view. The second aspect really of what I would say is that this idea that, oh, they're unresponsive, and so we understand the content of their consciousness. We have to dispel that notion. We're arousal scientists principally, and most of the topics I would say here has been discussing about levels of arousal, and we haven't really delved into the topic of content of consciousness because that's incredibly difficult to do in animal models. And that's going to be a major obstacle for consciousness science in general. And part of our motivation with sensory disconnection is we're trying to simplify it down into something which we think we can study, but again, getting an animal to report whether they experienced a stimulus is not going to be something that's particularly feasible or easy to do.
I just want to follow up, and I want to ensure that nobody had the impression that we're at odds, although that's okay. I mean, it's a scientific discussion. But as we were discussing yesterday, I do appreciate the distinction between the groups that are interested in what is the neurobiology of even having 1 pixel of experience versus what I'm interested in is how are we conscious, or why are we conscious in the way that we're conscious right now, and how does that go away? So I do agree that the nomenclature is important. It's important to be on the same page, and it's confusing because some people don't even believe that the distinction between level and content of consciousness is meaningful. And like Tony Hudetz and Adrian Owen and others have tried to argue for how this is really more complicated. I think one thing I would add in terms of, are we getting closer or what would we want? I think we need to have a better understanding of how to measure information, or what does that mean and how can that be assessed? Because I think a lot of the different theories and a lot of the different approaches want to ultimately understand that. And I don't know how well any of us could make a claim to really measuring that currently. And if others disagree, please feel free to.
And I would actually argue that I think it was a strength of the presentations really to emphasize the spectrum and really point out the differences in what we all mean by consciousness versus unconsciousness, and really emphasize that there's so many different levels and we need to be very clear on what we talk about. I would think that we have interests in very different aspects of this. On the human philosophical level, I think consciousness as a very complex function is hugely fascinating, and hopefully we'll learn more about that, driven by many of the brightest of us. But then I think also that on a clinical everyday practice level, can somebody be aware enough to squeeze my hand during surgery is highly relevant for us. And for those of us who are intensivists, can I get my patient back to where they follow commands is hugely important. And so I think gaining insight into that and possibly creating predictive models that allow us to prognosticate early on is going to be hugely important, even if it is not the same as these complex levels of consciousness. Let's try to get through the last questions. We're running out of time and we'll need to vacate the room, but please ask your question.
Yeah, great panel. Ben Polaka, Washington University in St. Louis. I was curious in the panel of whether each of you have like an ideal state that we would love to target patients under general anesthesia, either a state of consciousness or a state of brain activity, and whether those states we need better consensus in our field. And finally, do you think targeting those states might have some unintended consequences in terms of clearing toxins out of the brain, maintaining homeostasis of synapses, anything like that?
Rob?
Well, obviously, I've got an axe to grind, so I get to grind first. So I think sensory disconnection is an interesting possibility. Whether it's got a clinical applicability and whether we can modulate the states and hold people in these states is completely unclear. So yes, I would like all my patients to be dreaming of lying on a beach, sipping a mojito throughout their neurosurgery, if possible. Do I think I can achieve that for my patients? Even with my ego, I don't think I can. Do I think that unconsciousness is an acceptable state under anesthesia? Absolutely. Do I think there could be unintended consequences from any of these states? Very possibly. There are unintended consequences, I'm sure, from anesthesia, so their relationship to these different states, it's unclear as to whether there could be a downside to dreaming. I can't think of one, but maybe someone, smarter can.
One more?
Hi, my name's Jan Carstoniu. I'm a clinician from Toronto. With respect to consciousness and sensory disconnection, has anybody ever looked at people who are highly susceptible to hypnosis to the point they can undergo surgery with hypnotic suggestions alone and have a conversation with the surgeon while he's taking out or she's taking out the gallbladder? Has anybody done that kind of work?
I must admit, I'm afraid I'm not well versed in it. I know from informal discussions with Stephen Laurie's group that they've explored that. I don't know, Vincent, you have any comments, but it's in a very intriguing area. It's certainly an area which has been investigated. I don't know the literature well enough to comment, I'm afraid.
Okay. Thank you again. Many thanks to the audience for your fantastic questions, and my best thanks to the panel for fantastic questions.